Fantastic. Thank you. Good afternoon, everyone. Welcome to the Pediatric Readiness Recognition Programs Collaborative. We are at session 7. I think we are officially halfway, I believe, for the April 18th session. So if we'll go to the next slide, we'll get started. As a reminder, our funding acknowledgement, the Pediatric Pandemic Network and the EMSC Innovation and Improvement Center are supported in part by the Health Resources and Services Administration of the United States Department of Health and Human Services. The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. And if you want more information, you can visit the website. So again, thank you so much for joining us today. We've got quite a talkative session. Hopefully you'll get a lot of information. This session is being recorded and it will be posted on our website. If you have any questions at any time, feel free to raise your hand or come off mute. You can also use the chat function. Today's session is going to be interactive and we'll have some fantastic discussions. So we'll go to the next slide. Here is our agenda today. We're going to break it up kind of half and half. We are still working on the minimum criteria for both pre-hospital and emergency department programs. We have completed round 3 of the ranking. So we just want to go over those final criteria and make sure we have the correct wording on that. And then we're going to talk to you about our schedule and future topics. And then we'll spend the last 40 minutes talking about the application process for recognition programs. So then we can move forward and I will hand it over to Kasey and we can jump into our pre-hospital recognition programs minimum criteria discussion.
Thank you, Julie. I see Eleni has put in the chat a link to view the results. Included is the results for round 2 and 3 for both ED and pre-hospital criteria. So that is the overall results. And then if you would like to see your state's results, you can also message Eleni and she can get you the link to your state's results. So thank you so much, everyone, for getting in your results for the 3rd round. We've made it 3 rounds. So really appreciative of all of your hard work and reaching out to your teams and getting others involved in the process. And we're excited to review that with you and discuss next steps. So as a reminder, we had discussed previously setting a score, a point in which we would put forward the criteria as recommended minimum criteria, and then others as stretch or optional criteria. And again, this is all around minimum recognition criteria. So this is for pre-hospital criteria. And again, you can see this more clearly in the link that Eleni put in the chat. But this is looking at both round 3 and round 2. We did see a little bit of shift in criteria that was above that 4.4 scale and those that maybe fell below it this time. So there are, I believe, 8 criteria that are above a 4.4 with an overall average score. So we'll get a chance to look at these a little bit more closely. This is just looking at round 3 results. In the other view, you can see the changes that we made in the verbiage of that criteria. But again, we're looking at the average score. We also want to take into consideration the range, and that helps us see how close we were to consensus around that item. So the smaller the range, the closer to consensus between our minimum score shared and the maximum score shared. So you can see that there. Are there any questions about the overall results for round 3 for pre-hospital criteria? So Emily, if you want to maybe come off mute and share your thoughts on that with the group.
Yeah, I've shared this in past sessions, and if I'm alone on this, please tell me so, because obviously we're doing this as a group. But that the cutoff of 4.4, I don't personally agree with, because I think that that is too many criteria for our lowest tier. But if everybody else thinks 8 is reasonable for your state or territory, then please, I would like to hear that.
Like Cynthia might be having a hard time with audio. Is anyone else unable to hear?
Hey, Emily, can you expand upon that about your concerns with the lowest tier? Perhaps give an example of your concerns with the challenge.
Yes, I think that a lot of states and territories have multiple tiers. So if this is going to be the lowest tier, then obviously you have to build from there. And that a lot of my colleagues in other states have expressed a desire to have the lowest tier be kind of your entry level, so that you can be engaged and that you can actively be part of the system and work towards getting to a higher level or a higher tier, that it's not that it's within reach, so that you can engage, make it accessible, something that all agencies feel like they can accomplish.
Thank you. Just to follow up, so the ones that are not in blue, are you thinking that for the lower tiers, an emphasis on, policies and procedures help bridge that gap?
I'm not sure I understand your question.
No, for your lowest tiers of people who want to work towards this, and may not be able to. I'm still trying to understand, everything in terms of your concerns as far as that's
This is Rachel.
how does the blue, I guess my question is, how does the criteria in blue exclude the goals or your lowest tier people?
Pat, I think Emily's point, Emily, and correct me if I'm wrong, this is Rachel, that if this is minimum criteria and for states with multiple tiers, this is a lot for the 8 things is a lot for one agency to try and accomplish to be part of simply the lowest tier of the recognition program.
Yeah, I think that's accurate, Rachel. Thank you. And because it's minimum, it doesn't mean that if you have only one level of recognition in your state, you can include all of these. But if you have a minimum level and you have, I don't know what's the most tiers that somebody has, but go ahead, Cindy. I think she has a point.
No, I was going to let you finish and then see if I heard you correctly.
Well, go ahead, because it's all hypothetical for me, because I don't have an active system or like an active recognition program for pre-hospital. So states that do, or states that are further along in this journey, please speak up if I'm not accurately representing your concerns.
What I heard Emily to say was not to necessarily get rid of what is not in blue, because what is not in blue is sort of step 2 and step 3. And as I've looked at the Pennsylvania system that currently is 6, some of what's not in blue is what you need to be at the highest level. I also think I heard her say what's in blue could be stepwise. So we are in development, but what I, as a future grandmother, would want is that all equipment and supplies are available, that medication dosing training is required, and that they can locate that equipment. Some of those policies and procedures could be the next step. And it really depends on what you call policies and procedures. And so processes and procedures is one thing. Policies may come from a state, may come from a region, may be very local. And I think that's where I see, let's get what saves lives, then let's what puts quality improvement in place as a second level. And I'm hoping we don't go to a third level, but sure, you could group some of those. I don't mean to put words in your mouth, Emily, but that's how I visioned it as you were talking.
Might any of the group consider putting, you know, like the level of effort or associated with each of those criteria? For instance, you know, not started, complete, and those play into crediting those agencies that have who are working towards these criteria.
So Kasey, will you go back to the last slide?
Well, I think also Scott's been trying to have
Oh,
it
okay. Absolutely.
Yeah, I guess two things that worry me with this, and I kind of mentioned it on and off throughout, is by us setting up this minimum criteria, it sets the standard. And so then us as a state, if we modify this minimum criteria that we've talked about, we're now deviating from the standard. So it's just, you know, when you look at NFPA with fire departments, you know, if a fire department does something wrong, no matter what, they're held to that standard that NFPA sets out. And so they're held to that industry standard. The second is, you know, on the step frame, you know, I know in our state, we're going to have some, you know, some services like, what's the minimum thing I can do to get something? And they have won't have any desire to go any higher. So, you know, that's one of those things to look at. I know Montana, and I think I saw that Kelly is on. I know Montana has this tiered process in place, and she may be able to throw some light on kind of what they do. Sorry to put you on the spot, Kelly, but you know, so that's some of the things I worry about as we, you know, continue to, you know, go down this, because we ended up having to put our whole program on hold for now almost a year, kind of waiting to see what happens with this, because we know we're going to have to change it based on the outcomes of these processes.
I can respond to that. Thanks for putting me on the spot, Scott. And I do, Jason Mahoney, who also works with me on this, is on here too. So feel free to jump in. But I quickly wanted to respond to Pat. We also have a hospital one into her last question about, could you say like in progress, working on? That would be very hard how we recognize our EMS agencies, because you're either recognized or you're not. We have the multi-tier system, but the multi-tier system too is because we have a huge amount of rural volunteer EMS, and that lower level is targeted towards those folks that aren't an ALS agency, etc. But I don't, I mean, you either meet it or you don't. I'd be curious to know what other folks that also have programs, how they address that, because it is a good point to allow more people to be recognized, but then it's kind of like, well, how would you even recognize them if they're working on it? I don't know if Jason had anything to add, not to put him on the spot, but.
No, I don't have anything really groundbreaking to add. And you know, to the point that's been made earlier, we have in our tiered system, most, if not all, of the things that are highlighted in blue here, but we have broken them up. So it is a little easier for someone to get their foot in the door. You know, our lowest tier requires a PEC, the basic equipment and supplies, and then participation in the assessments, the pediatric preparedness assessments. So that's how we start our lowest level, and then go up from there with more requirements.
This is great discussion, and also want to make sure that reminder sort of the process, we're recommending minimum criteria that can be used as the consensus-driven starting point for your individual state recognition programs. So a starting point to bring to your group and present is, we came together consensus, and these are items that we would recommend as minimum criteria, but then your state has then the ability to amend that and make it appropriate for your situation. That's a great question, Rachel, and definitely one that we wanted to bring to the board to discuss. We can move ahead to that one and look at it. So for policies and procedures regarding the reporting of child maltreatment, did have a range of 4. I will share that 75% of the scores were a 3 or 3 to 5. So there was not a large percentage of those scores that were below a 2, but it does have a range of 4.
Isn't everybody a mandated reporter?
That was a very common comment that we received. But this would be sort of an easy, achievable one.
Yeah, but it's like, it's covered under other requirements, in terms of, legislative and legal authority. So it's like, why are we including it here?
I agree with Pat. I don't think you need a policy for something that's required as part of your position.
I think when we talked about that a while ago is because not all states are mandatory reporters, is why that question went in there.
I think that's a federal requirement.
No, it's not. Reporting it is required for certain people, but not all EMS. The last time we had information from HRSA, it would really be helpful if an update could be done of all state laws. There's probably somebody in the Department of Justice who can do that, but I don't know who it is. But the last time we looked at this, which was about 5 years ago, not all states had that requirement, and not all territories did for emergency services, first responder clinicians.
And I know here in Montana, I've been a mandatory reporter as an EMS professional for my 25 years, but we still to this day fight to make sure that everyone understands that they're mandatory reporters and what that requires. So for me, even though it might be duplicative for most of us, it wouldn't break my heart if we were using this platform to kind of reinforce that and make sure that everyone knows what that's all about and we're actually getting those reports. Because I know that doing QA/QI for an EMS agency, there's been a few that have nearly slipped through the cracks despite state law and things.
Yeah, and the other part with that is like in Wyoming, it says that we have to mandatorily report, but it doesn't tell us who. So for us, just walking into the ER, letting that ER nurse know in our patient handoff report, that satisfies that requirement for EMS here. So that's the kind of the downside of some of the state laws.
Great discussion. There's been quite a few comments in the chat. Now, I've probably missed some of these comments, so if you would like to come off mute and share that with the group, go right ahead. We'll go ahead and move on to the next one. So this is that pre-hospital personnel can locate pediatric specific equipment. It have a smaller range, a range of a 2. And then if we look at the average score, scores for feasibility and importance, and then we can compare that also to the round 2 results. So we had a 4.6 for the 3rd round and a 4.5 for round 2. So it came up a bit in terms of how we felt that it was feasible and important to be recommended as minimum criteria. A lot of comments. I want to open it first to the group, and if there's anyone who feels strongly about this, confidently could recommend it as minimum criteria to your state, maybe share your position, or if there's someone who might be a little bit more reserved or have some concerns about this one, feel free to share.
With us here in Mississippi, this is a minimum criteria just to be an ambulance service as a either a basic or an advanced level provider. They have to be able to locate every piece of equipment in the ambulance just starting out, and that's the only way that you maintain a ambulance license or your EMS license here. So it's easy to integrate with us and make it a requirement.
And Josh, isn't it common practice for the field providers, you know, when they're off shift to, you know, do their equipment checks and make sure that the equipment is available for the next run, or whoever's coming on, to make sure that that's the case?
It is, for any shift change, the way that it is supposed to work is the transport unit is prepared for shift change and then verified by the oncoming shift to make sure that all the equipment is in place, supplies are in date, things of that nature. So that is common practice, and that is required for us as a state to maintain levels of readiness. Now, this doesn't include fire departments or our first responder agency. This is strictly ambulance companies.
Yeah, I'm sorry. Even if I speak to Josh. So we, as the agency, don't regulate the fire departments in terms of supplies and everything. We just regulate the ambulances and make sure that all their stuff is in check. So if I don't know, like a fire department has access to medications, or maybe they have access to ET tubes that relate to pediatrics, we don't actually check their expiration dates because we don't regulate them. So I don't in our state, I don't know how we can govern or even make sure they're pediatric ready, because there's no governing body that we can do anything about. For EMS side, for transport agencies, we can.
And I think the other part of this too is I like the idea. I know it's something important, but what's the metric for showing this? To me, the way this reads is I need to show up and test every person on that service. If I read this literally the way it's written, or do I just trust the service director when I go out, or their PEC when I go out to do an evaluation of the service, that they've done that with all their people? So I guess that's my only issue or kind of concern with this, is how do we measure it?
Is there anyone who currently implements criteria similar to this in their recognition program that can speak to how you might look at that? Would it fall similar to how you're looking at skills evaluations for ED recognition programs similarly? Would that be if we could think about something that might be similar that is being done?
Generally, when nursing does competencies, they have a document they fill out to prove their competencies, to prove they went through the process. So it would just be something that we would have to implement on a much wider scale.
What are some other thoughts about how that might look?
Can we use attestation documents that the service is saying we do this or we meet this criteria? But we're reviewing our program in PA, and we're considering a lot tighter process that would have forms for the service to complete to verify, and the medical director, for example, would verify competencies were completed on this date or this time for their services, that they can then submit as part of their accreditation or recognition, whatever it's going to be called, or the renewal over the term of the recognition, so that it gives them a tool, but it's still not going to be in-person verify it. It's going to be attested to by an organizational leader or the clinical lead, medical director, or things like that. But at least it'll be more well documented than just a simple, yeah, we do that and we're one and done.
Thank you, Dwayne. Any other thoughts on this?
Do you mind if I speak again, ma'am?
Yeah, go right ahead, Andrew.
Yeah. So I don't know how to do it because I know some of the EMSC programs are not state based, and it would be hard for them to. I wouldn't say regulate, but kind of record that stuff. Just because a lot of these companies, depending on the company, that they may not, you know, welcome somebody just to stand on site and check off their trucks. But I know in our state, we're since we regulate our ambulances, and since we provide EMS license to the companies, and a lot of our companies are privatized, we actually send out inspectors to check off the ambulances. And when we check off the ambulances, we actually check off uh, the supplies they have there as well. And part of that is recording the expiration dates to make sure that they're in date, make sure they have a constant supply of it, check how many there's actually like amount of things that there's a significant amount of what we check is coincides with what you guys want, but that would be on the state level to do. And I don't know how. So speaking for the people that are not connected, like the EMSC server programs that are not connected to the state, I don't see how they would be able to do this. I know I would be able to do it because my secondary role is as an inspector for ambulances. I can actually check trucks to make sure all their stuff's in date. And when we do inspections, we check every single individual truck, and we do it like on a biannual basis where we check every service twice a year, every truck, so we know that their stuff is in check, in date. But I don't know how you would do that as a non state based EMSC program, or how you would even regulate that if that's what we're trying to do for the minimum criteria to check these supplies to make sure that they're in person, like in person checking to make sure they're in date without going by just word of mouth.
This is Tasha. In Tennessee, we are university based, but we are working with our state EMS office for our verification process. So they're actually going to be doing all of our verification for us. I don't know if other states are able to have that type of relationship or not, but when they go out and they relicense the agencies, they're actually going to be doing our pediatric checklist for us to determine which level that we do a self-designation format. So what level that they want to be designated as. They're the ones who do the verification for us.
So it's Dwayne again in Pennsylvania. Since we have this program and we've got 10 years of lessons learned behind it, one of the concerns we have is with the feedback we've gotten from the licensure people who do the inspections is because this program is not part of regulation, that it's not part of the licensing inspection process, and therefore it's not required. It's outside of the inspector's domain to do certain things. There was an expectation that they would verify that the services had the extra equipment that was required above the state list. But even that, with feedback from the inspectors, is outside of their purview under the regulation and the licensure manual that they have to follow. So it's a fine line of whatever state's regulatory component is. And to me, to be honest with you, I don't see this recognition program as a regulatorily enforced process, but it's voluntary unless somebody puts it into statute. And therefore, the process has to be a lot more loose than regulatory inspection of ambulances for inspection for expiration dates, stuff like that. I think that's getting too far into the weeds of the expectation of a readiness program, personally.
That's an excellent point. This is Kelly in Montana again. Yes, 100%, because our inspector is employed through my state office that I'm employed through. But how did that have teeth? One of the things we did is we ended up adopting as a rule the recommended equipment from our pediatric checklist as a state rule. So that when we can check the box, if the EMS agency is pediatric recognized, we're also verifying as an inspector in rule that they have the required pediatric equipment. But we dealt with the same exact thing.
Thank you so much. I don't know, Rachel, if you can share a little bit about what you know, the process that they went through to integrate that.
Oh, no clue. I just
Okay.
know it's in some programs.
It has happened.
Yes.
Okay. All right. So this is our, so that was 1, 2, the third criteria uses weight estimation systems. Again, this one had an overall average score of 4.5, a little less than we had during round 2, 4.6 then. Does have a small range, a range of 2, and then our scores for feasibility and importance are very similar. There were some suggestions to adjust the criteria to include specification for kilograms and to add word it as policies, procedures, and training to use weight estimation systems. Any comments to share with the group or points to discuss?
You know, it is a common practice that, you know, not to state a proprietary product like Broslow and refer to that it as either a weight-based system or tape or something along those. So definitely would reiterate the importance of not using a proprietary term.
Thank you. The next one would be a designated PEC who may support 1 or more agencies. And be the change from round 2 to round 3 to include the support of 1 or more agencies. Got a lot of positive feedback on that, but still some suggestions to shift it or to adjust it. Maybe more points of clarification regarding shift PECs or being able to support more agencies, supporting 3 smaller city fire departments or district PECs. I don't know how the group feels on that.
Hello. I'm agreeing to the regional PEC. We have a lot of rural areas north of Mississippi area and in our North Mississippi area, and we have a lot of volunteer fire departments that sometimes work together with regular fire departments, and a lot of these volunteers, there's only like, I don't know, maybe 4 people in total in the fire department, 5 people in total on their fire department. And I think having a regional PEC would be a lot better for them, just to kind of, work together, especially if they go between the other volunteer fire departments and they're able to talk to them. I think it kind of helps the situation where they know what their area has, they know the coverage area, they know, hey, we need this many stuff. And if they have a regional PEC, it's better communication between the volunteers and the fire department saying, if you guys run out of this, we have this. And I think having one person that covers multiple areas, even multiple people covering multiple areas, would help with communication between those fire departments. As far as the agency ones, I think depending if the agency covers multiple counties or parishes, I think that would help them too, because if they just have one person covering their whole company, they can go, okay, this county needs this county needs that, and it would clear up a lot of uh miscommunication between multiple people saying, hey, we need this, and then order something that they don't need. And for us, our situation is money. I mean, I'm sure that's for a lot of people, but funding and being able to not have to waste funding on reordering materials that you already have when you have communication is a lot better.
I think this idea of having the ability to have a regional tech is awesome. It's one of the things that we've done here in Wyoming is we've opened up our healthcare coalitions, and we're going to actually give them a little bit of funding to have a regional, not to replace necessarily agency-based or organizational-based PECs, but to supplement, have that second layer if necessary, or for those agencies like that don't have that depth in their agency to be able to have somebody that they can kind of roll up to help out.
Thank you. Any other comments about PECs? Right. So the next criteria is requires training on medication dosing for children. This one had a small range of 2. Overall average was a 4.4. Our feasibility is a 4.2, and our importance is a 4.6. So a little bit further apart there. And then we did have a decrease in the overall score from round 2 to 3. We were at 4.6 in round 2 and currently a 4.4. So training on medication dosing for children. There was a lot of comments or suggestions to add some clarity on frequency. Some other comments here. But again, if you would feel strongly about this criteria or either way, feel free to come off mute and share.
Is this including and I keep bringing up fire departments, but because they're part of the survey, are they included in this remediation training if they do it?
That's a great question. What does the group think?
I think to his point, we need to add terminology that says something like scope appropriate training. So when it's
Yes.
not necessary, it's not required.
Yeah,
Yes,
I think I would absolutely agree with that. I think that's a good point.
I agree with Dwayne as well.
I think this, then you have to define what the training is, and I think that's where it's a slippery slope.
I think this is a difficult criteria to actually work through because you have multiple levels of different providers this is going to impact, and you're going to have some folks, like Dwayne said, it's going to be outside their scope, and there would be no need for it. You're going to have others that it's well within their scope and there would be a need. So I think it's going to depend on the agency.
And this is one of those things that just goes back to having the agency document things and the medical director sign off, or the agency leadership sign off that they've met criteria within the parameters of what it's being put out there. So if there's scope appropriate training, the medical director would submit as a form, as part of an application or whatever, that they're attesting that the staff have met whatever the criteria is over whatever the term is, and they're signing off on it. And we really don't need to worry about the weeds. They worry about the weeds. It's appropriate at their level for their agency, for their providers and the provider scope. And we just give them the high level of what's the expectation.
I think that would be a good solution. And they'd still have a policy in place.
Looks like comment from Rachel Ford is getting a lot of traction in the chat. I don't know if you want to come off mute and share it with the group.
I don't have anything else other than what's written on the comment.
I'm just going back up to read it too. So your draft recognition criteria states all EMS providers on agency roster complete required pediatric education for their provider license type. Thank you. Right. Any other comments on the criteria or the results of the third round for the pre-hospital?
You know, I just think we have to be, recognize that even though we're trying to set these criteria, that within the criteria, there's just such huge variation across the country because of scope of practice, because of setting, because of utilization, cost, and the involvement of, medical directors and where the authority for the EMS agency or providers exists.
I think this is an example of that, right? Some of the comments were to add annually or quarterly. But as we're recommending minimum criteria, if we don't include those, it allows for flexibility and for states to bring that back as a starting point and to have those discussions with your team and decide what's the best way to move forward for your recognition program. Right. Any final comments before we move on? Jump ahead here for a second. So we have been made aware of some scheduling conflicts for next month's session. So I want to take an intermission and address that briefly, and then we'll move on with today's session. With that in mind, we wanted, with the known conflicts, we wanted to bring it back to the group and see if there was suggestions on how to move forward with that. We had considered rescheduling the session, using the session as an optional working meeting for those who would still be available and interested in meeting, or we can cancel the May meeting and resume then in June. So, don't know if I think there's at least 22 of you that are planning on attending a meeting during our next session. So we did want to address that. And we have a poll for you all to answer to sort of let us know how you would like to proceed.
This is Cindy, and I will own the fact that I'm the one who brought it up.
Yes, I appreciate it.
When I was planning for May, I would suggest, with the exception of New Jersey and North Carolina, who have completed their national pediatric pre-hospital, I reversed those names, survey, with us launching this first ever baseline national survey May 1st and having an ASEMSO meeting in Pittsburgh at the same time, I would make a motion to just cancel May and pick it up in June. I think we all have enough on our plates in the month of May. And that gives North Carolina and New Jersey extra time.
Of course.
I would agree to that just because I'll be out of state going to Pittsburgh in May, and so will my manager. So both of us will be preoccupied with the NAMSO. And even though ours is done before then, I know that if there's any questions that our services have comments or questions about during that month, it would be difficult for us to answer them.
Appreciate your feedback, and I will get that off of your calendars and we'll come back together in June. That it's consensus. If anybody is interested in meeting with us still in the month of May, you can reach out to Julie and I, and we can set up a meeting and catch up and see how your recognition program is going. If you have any specific questions, we're still available to meet with you. But we understand there's a lot going on next month. So thank you so much. All right. Julie, I think you're next up.
Hi, everybody. Let's see, I'm putting Kasey's email and my email in the chat so that that offer does stand. If anybody wants to meet in May and discuss anything, we can have office hours. Just email us and let us know. So if you'll remember last session, I think it was last session or the one before, we asked you what you needed in the future. And so it was 2 sessions ago. We wanted to know from you what you wanted as far as the sessions in the future. And so last month we talked about communications and how to market your recognition programs. And then the next topic people wanted was about the application process. So instead of hearing from us and us lecturing and telling you what most programs have with the application process, we decided we're going to bring the experts to you. Now, several of you on here are experts, but we chose 2. We just reached out to 2 people that we knew had application processes in place. And so we are going to have Morgan Skaggs from Kentucky and Evelyn Lyons come off mute, and you can also turn on your cameras if you wish. And we're going to ask them some questions and have them talk about their application processes for their readiness recognition programs. So before we go on, Evelyn and Morgan, would you introduce yourselves, please?
This is Evelyn Lyons. I'm the EMS for Children manager in Illinois.
Hi, I am Morgan Skaggs, the EMS for Children program administrator now is my title in Kentucky.
Thank you both for being here. And Evelyn, I apologize. I don't think I said you were from Illinois. So my first question is kind of looking at the big picture of the application process. Will you tell us about your state's recognition program's application process? And let's point out that Morgan is going to address the EMS pre-hospital process, and Evelyn is going to specifically address the ED and hospital side. So will you tell us about your process? Evelyn, you can go first, please.
Sure. So our facility recognition program for our emergency departments and hospitals has been in place for quite a while now. We piloted the process back in 1998 and then rolled it out, began rolling it out statewide in 1999. And it really helped for us to do that initial pilot because we focused on 2 regions of our state. Our state's divided into 11 regions, and we thought it would be helpful to get both a rural and an urban perspective. So we targeted a rural region and an urban region, and then utilize that pilot information to refine the process a little bit better. But that also made us think more towards that bigger picture that you just mentioned, for us to look at how we would then do our renewal process once we finish doing the actual initial application. And that's when we decided that we would continue to roll out the program on a region by region basis, because then that allowed us to just focus on a targeted region at a time. And now, as we've gone back over the years to do their renewal and their re-verification, it helps us to just focus on a particular geographic area at a time. And then they submit renewal applications. So every 4 years, we revisit the hospitals in regions and do their renewal. We have 2 application cycles per year, and the application process has been refined over the years. So it started out as a paper process, and it's now an electronic process in which they submit their applications. And then we make a determination based on a review of their application, and then we set up a date for their site visit, and have additional material that we ask for them to have available at the time of their survey.
Morgan, how about the application process in Kentucky?
For our pre-hospital program, which is significantly different than our hospital-based program. So our pre-hospital recognition program is recognizing agencies for the 7th year. We started with a sort of focus group of EMS providers, people who were going to become PECs for their services, and we tried to have a good cross-section of rural versus urban, fire-based versus county-based, small versus large, kind of making sure we kind of covered everybody. And we talked about the couple of programs that were in existence at that time. We talked about our performance measures and established our sort of baseline criteria for a single level recognition program. And it has changed some over the years. We started off with sort of a rolling open application process, and you could come in for year 1 with a plan on how you were going to meet all of these things by the end of the year, because we wanted to start right from the beginning, having some agencies in the program. And we've now changed that to where the application window is from January to the end of March. So they have the first quarter to get their paperwork in. Applying for recognition in 24 meant that you were documenting completion of all the criteria for calendar year 2023. So we're always kind of looking back at the year before and seeing that they met all of the criteria. And then they apply every year for renewal. And so I review all of the applications. We get a demographic page. We do have the chief officer within the agency sign an attestation to their commitment to meeting the various elements. And then we ask for specific reporting on 3 criteria: community outreach, education, and skills competency testing. And then we also look at safe transport as well. So we get some reports on their policies as well as which devices they're using. And so I review those applications and put together a report for our advisory committee. And we discuss any that are not clear-cut yeses or clear-cut nos, and talk about the reasons why we think they should go one way or the other. And then ultimately the committee votes to approve the list of applicants that we have, or which ones we're not going to approve. And I just sent notification out today to those agencies. So we have 34 agencies recognized this year out of about 160 statewide. That And we get regular inquiries from agencies on how to get involved. And we do make our handbook and all of our application documents available in Basecamp, or I can email them to someone if requested.
I want to come back to that. I heard from both of you the word we and I. And so I'm going to ask you to talk about that a little bit as far as and we're going to go way back. When you first started developing the recognition program, and you said, okay, first thing we need to do is have an application process. What is that going to look like? Who was involved in that process? Like I said, I heard a lot of we. So who was involved in that process, and how did you get them involved? Or was it just you?
No, in Illinois, we had a really pretty robust collaboration. We had established our state advisory board, and it was the advisory board that defined specific areas of focus, one of which was to develop a facility recognition program. And so they authorized the development of a task force. And so on that task force, we ensured that we brought on board representatives from our state emergency, our state ACEP, state AAP, State Emergency Nurses Association, a number of other professional organizations, as well as assuring that we had folks at the table who currently were clinically caring for pediatric patients in emergency departments, and utilize those folks as kind of the clinical experts to be able to let us know if criteria as it was being developed, if it seemed reasonable or if we were on the right track. But we definitely had a group that was involved in this effort. There was a lot of back and forth as we moved along with the process. And actually that task force ended up evolving into a standing committee. And we continue to have a facility recognition committee that continues to meet today, because there is always components that we are updating or reviewing. There's also guidance documents that we've developed over time that we want to make sure that we're as transparent as possible and as helpful as possible to provide the hospitals with resources that they may need to proceed with the process. So the materials, the application materials are online and easily accessible. And like I said, we've continued to have that committee meet. We meet every other month and continue to explore areas and opportunities for improvement within the program. We have over 100 hospitals that currently participate, and continue. We're working right now with the Illinois Critical Access Hospital Network in our state to try to improve the participation by critical access hospitals. So we're always trying to reach out to new groups to see if we can work with them further.
And what about the EMS program, Morgan? How was that difficult to get people involved?
Not terribly. I but let's see, this was 2017. So I had been in my role for 6 years and had a fairly good list of contacts for every agency, and had people that I had communicated with pretty regularly or that would contact me for resources or questions. And so I basically, when I wanted to form my focus group, I just put out an email call and said, hey, I'm forming this group. We're going to be developing this program. I want input from providers and agencies. And I got a pretty good response, and pretty much everyone who responded ended up on the group. So I think, had 7 or 8 people that were involved, and I was lucky enough to have good representation of the different groups I wanted to be on the group or the committee, the work group. We actually originally had started with the development of a tiered system. And had 3 levels, sort of a gold, silver, bronze. And when we went back to my colleagues in the state EMS office, I actually got pushback from them on that. They felt it was confusing. They didn't understand what the difference was in the 3 levels, and that they thought somebody getting involved at the first level would not be particularly motivated to move up. That they would get that sort of public recognition from having that decal on the truck, and that the public wouldn't understand the difference. I'm not sure that I was completely on board with that, but when I went back and talked to my focus group, they were in agreement that they kind of like the idea of a single tier better. And so we shifted gears sort of midstream and consolidated into a single tier program. We did take everything that we developed to the EMSC Advisory Committee for review and approval, but the actual work of putting the documents together was something I did. I borrowed a little bit from the Pennsylvania program and copied some of their documents, and then tweaked them and changed them. You know, I borrowed heavily from our performance measure manual when I was writing our handbook for the program, specifically for the education and skills competency sections. So yeah, I did the kind of the grunt work and then presented it to those groups for feedback.
Thanks. So let's talk about, and this goes to a question in the chat. How do sites, say a site says, I want to, I've heard about this recognition program. How would they find information about that? And what kind, and I've heard both of you mention like materials, and they can look on Basecamp. So will you talk about that? How do sites get more information about the process of applying? And do you have education materials for them, and how would they access those?
So in our state, because we do the renewal process on a region by region basis, we have an educational session when that region is due for renewal. Now, any hospital that has not currently received recognition, they can apply at any time. And we'll do one-on-one education with them. And when I say we, I'm referring to myself and Kelly Jones, who's our EMSC coordinator. So we can provide one-on-one training, but when it is due for, when hospitals in a region are due for renewal of their application status, we hold a educational session in that region. And all of the hospitals, not only the ones who are recognized, but the non-recognized hospitals are welcome to attend as well. And we provide information on EMSC, on the facility recognition program, what the expectations are, what the requirements are. We walk through the application itself and answer any questions that they might have, and also direct them to the website where the materials are located, as well as any other resources that might be assistive to them in the process. What's really helpful are checklists. So they find those helpful because then it's really clear what they need to be gathering and putting together as part of their application package. We also have tried to work to make the forms in a fillable format. So those also are helpful for them to be able to fill out certain forms by entering in, for example, we have credentialing forms for the physicians, nurses, and advanced practice providers, in which they need to identify all of those individuals on the appropriate form, and then identify their their qualifications, and then their attainment of pediatric education. So those are forms that are already templated. They can just go ahead and fill those in, and then those are part of the application as well.
I got distracted with answering somebody's question in a message. Remind me what I'm asking.
You're, how do sites get more information about the application process?
So
And
some of that was, yeah, what I was hitting on. So we talk fairly frequently about the program and use any opportunity we can to acknowledge the agencies we've recognized. We use social media. I usually do some sort of poster at our state EMS conference. It gets announced at our board meeting that's held at the state EMS conference, and we read off the list of names or share written documents to highlight the agencies. We'd have a monthly EMS administrators call, and I bring it up at least a couple of times a year on that call. But the Basecamp platform is something I use extensively in my program. So I pay $11 a month for a personal account on Basecamp. And then I manually add a contact for every EMS agency and every hospital in my state into that program, at least one. I try to keep limit to no more than 2 or 3 people per service or hospital, because I have different projects. So I have an EMS group, I have an ED group, and I can add them in as an outside collaborator, meaning I don't have to pay for their access. And then I use that platform widely to share information. So I can do announcements. I store documents, including all of our recognition program documents, the national guidelines for pediatric readiness documents I have in there. I can put videos in there, and it gives them an easy way to access and download it. And it gets us around most of our firewall problems at sending stuff out by email. And it really encourages more engagement in the program, because I get people all the time calling, how do I get access to this Basecamp thing? And it's like, well, you have to be named for your service as the point of contact. And so we use it a lot. I also still do general emails to just a contact list. We have a quarterly newsletter that goes out, and I'll include blurbs on the program and the recognition of the different agencies each year within that. So it's a multifaceted process.
The other avenue that we have for sharing information is, one of our criteria is that each of the hospitals have to have what we termed a pediatric quality coordinator, and this preceded the term PEC. So that's the nurse PEC, and then we also have a pediatric physician champion, which is also known as the physician PEC. But the nurse PECs, or the pediatric quality coordinators, they're required to meet on a regional basis with the other pediatric quality coordinators within their region. So they each region typically meets quarterly, and all of the quality coordinators from each hospital come together, and they work on a joint quality improvement program or project. They also use that as an opportunity to network, to share resources, to invite others to educational opportunities that they're hosting. And some of the regions have actually held their own pediatric symposiums and conferences over the years. So it's really a nice networking that occurs within the regions. And then Kelly has the contact information for all of those individuals, but also has contact information for the chairs of each of those regional groups. So she's able to send out updates, resources, lots of information from the national program, the EIIC, as well as other resources, and then sends them to the chairs of each of the committees, and then the chairs disperse it further to the hospital representatives that they're in contact with on a regular basis.
And as you have those resources and things available to them, one of the things that we've been discussing is in many avenues, as far as IT, like Basecamp might be blocked. Google Form is blocked. Do you ever have those issues, and how do you get around those if they can't access the materials?
I work with pretty much any platform I can get access to that they can also get access to. So if somebody can't get into Basecamp, and they can get into Google Docs, I'll send it a link to them to download from there. I've used Dropbox, Constant Contact, Basecamp. There's probably 2 or 3 others that I haven't used as often, but if they say this is what I can access, then I'll find a way to utilize that program for them. And I also sometimes try to do straight emails and just include pictures and things within the email, so it's not an attachment. Sometimes that's one way to get some information out that doesn't get blocked, and then they can either get what they need from there, or, I mean, if it came down to it, I'd hard copy mail them if I had to.
So I had this question later on, but let's go ahead and address this. A couple people have asked, do you charge a fee for your recognition program to apply for the application?
No, we have no fee that's charged for the application process or the survey process. We never have charged a fee and don't anticipate that we will, because none of the our EMSC program is based within the Illinois Department of Public Health, and none of the other recognition programs, such as our trauma designation program, perinatal, none of them have fees attached, and I wouldn't anticipate that we ever would in the future either.
The EMS recognition program does not have any fees attached to it to apply. Our hospital-based program does, in the sense that we charge a $500 application fee, but we waive it for critical access hospitals. And then we do use that $500 to pay the physician on our site visit team for their day or travel expenses. We don't give them anything beyond the $500. The nurses that travel for our site visit teams usually go on duty. So most of the time I don't have to pay them. But if I did, we would pay them $250 for the day. So most of the time my program's absorbing that payment, unless it's one of the hospitals that paid the $500 application fee.
Evelyn, what about your surveyors? How do you compensate them?
I just put it in the chat that we use our grant funds to, it's just a nominal amount. I wish we could provide them more, but we just provide them a $200 a day stipend. And then we also covered their mileage expenses. And if there is a need for overnight lodging, then we will also cover their hotel as well.
So let's talk a little bit about the actual application. So we've got the process, but the application itself, what are some of the things that you have? I mean, you've got name, contact information. What else do you ask for on that application?
So within the application, if it's an initial application, we do like to see, for the initial application, we ask them to expand upon their emergency department services, their scope of services, their pediatric, how they define pediatrics. We like to get a better perspective of the kinds of services that they provide, if they have any pediatric inpatient or nursery services. And so there's a number of demographic type questions that that's helpful to give us a better picture of the facility itself. And then we also ask for formal documents that will help to ensure that moving forward, they will be compliant with our requirements. So it almost, when we were first developing it, it was almost as essentially we did a crosswalk between the requirements and then what we were asking for in the application. So for example, for the educational requirements, we would be looking for a policy or a annual competency document or some kind of a formal document that's dated and then is reviewed on a regular basis that would outline the pediatric requirements that your physicians, nurses, or mid-level practitioners would be required to meet. We also ask for other documents such as their quality improvement, specific pediatric policies. We also have a checklist for equipment and supplies that they need to complete to identify whether they have those items in place. And if there are some reasons why certain items may not be immediately available in the emergency department, they can submit for a waiver with rationale as to how they can access that item if it's needed. For example, a fluid warmer might be stored in their OR versus in the ER. And as long as they can show us that they do have it and are able to access it in a reasonable amount of time, we usually will approve that waiver. There might be also certain medications such as cyanide kit that they prefer to keep in the pharmacy versus in the emergency department. And again, they can submit a waiver for that. It's a required item. And as long as we can see that they do have it in the hospital and how quickly they could get it to the ER if needed, we usually approve that. So those are just a couple of examples of where we might allow for a waiver, but for the most part, it's really pretty rare that the waivers are approved.
For our EMS recognition program, our demographic page is pretty straightforward. Agency name, address, director name, medical director name, the name and contact information for the PEC. And then the only other detail on that one is we offer our decals in 2 colors. And so they get to pick which color they want and let me know how many they would need if they are approved. Because we send those out every year with the year noted on the decal, so they change them out regularly. The attestation is a pre-printed page that the director signs. The largest document that we ask for is what I call documentation of criteria for the previous year. And so within that, we start with education and we ask for number of staff on their roster, the number that completed the minimum requirements, and to calculate that percentage for us. We ask for a list of the topics and number of hours of pediatric education that they did, and the dates that those fell on. So we get a fairly robust list from some services and a very minimal list from others. And then we ask about any strengths, lessons learned, obstacles that they overcame, other challenges. And then we also ask for kind of a forecast of what they have planned for the following year as far as education. And then we basically do that for all 3 elements. With the community outreach, we ask what they did, where they went. Some of us give us 3 pages of community outreach events and others just do the 1. Some of them include pictures, which are fun to see and gives me a stash to pull from for other things that I can reach out and ask permission to use sometimes. And then the skills competency section, I ask how they determine which skills to check on. And I get answers that range from, we just pick the skills that match our Con Ed topics, to we do what was included in the PALS class, to, hey, we actually looked at QI and felt we needed to do some review on this particular skill. And that's how we chose what to do this year. And then I asked for the same demographic kind of content numbers for how many staff, how many completed at least 1 skills competency evaluation, and to calculate that percentage. And then we want to know what skills they checked off on. And then we give them the same opportunity to just freely report any challenges or problems or strengths or things that they want to brag about, and then what they have planned for the following year. And then we had added a safe transport device reporting form. And oftentimes they will still, even though I've told them once they've sent it once, they don't have to repeat, they still tend to send me their safe transport policy every year.
Okay. Both of those were a lot and of course needed. So from the back, and so the site is going to fill that out and they're going to submit all this. But how do you track that? How do you track their application data?
On an Excel spreadsheet that I fill out by hand with
Okay.
each one that comes in. And luckily, right now, of the 34 agencies that we recognize this year, 32 of them were in the system from last year. So I just got to copy that page over and update it, and didn't add 2 more to it. So it was not as much work this time around.
We
Evelyn,
actually, yeah, we have a database. Originally it was an Access database. It's now been converted over to a more current program, but we use that database to enter in if there are obviously the hospital information, but also to identify if there is areas within the application that more information is still needed, or if the documentation that they submitted isn't as appropriate or doesn't meet exactly what we need, then we're able to document that. So we can go back, and all of this is archived, and we can easily retrieve this electronically to be able to identify based on the checklist of what they needed to submit. You can easily go in and you can see if what they submitted for a certain item was okay, and then we just have a little okay that shows up in that box, or if there's still additional documentation that's needed or further clarification that's needed, there's that narrative information gets typed in terms of what exactly is missing or what needs to be clarified further. And then electronically, once that's completed, we're able to then auto-generate a application review summary document that then gets printed out, and we can have a hard copy of it. It can also be emailed to the hospitals electronically, and it's essentially the checklist that they used, and it'll either have an okay next to those areas in which everything was fine, or it'll detail what specifically is still missing and needs to be submitted. And they receive that checklist, that application review summary, along with the letter stating when their site visit is. And then there's also a companion document that's a site survey process document. And that walks them through what the expectations are for the site visit. And we also have a separate virtual session with the hospitals to review the site survey process document. So again, just to prepare them as much as possible and to make sure that they fully understand exactly what's going to transpire and what additional documentation we want to see at the time of the site visit. So for example, in the application itself, we ask about their quality improvement, what monitors they're conducting. We want to see the monitor tools that they use for the required EMSC monitors, but we don't want them to submit any QI findings or data at all. We don't want there to be any potential PHI, any protected patient information that's submitted with the application. We prefer to review all of that at the time of the site visit. Also for medical record reviews, because we'll look at medical records when we do the site visit. We also don't want any of that information to be submitted with the application, but we make them aware that there are medical records that we will be reviewing, and it's typically the physician surveyor who does the medical record review, and they will also do a cross-check with treatment guidelines or clinical pathways or any kind of protocols that are related to that particular type of condition that the child is presenting with in that medical record review, to see if they're following their own medical or their own clinical pathways or treatment protocols. So there's documentation that we request ahead of time in the application, and then there's additional documentation that they need to have available at the time of the site visit. And all of that is logged into our database. And then after they complete their surveys, after the surveys are completed, then we have additional documentation that is done, that they receive a post-survey letter that identifies if there's still anything remaining that needs to be submitted, and it will also identify some recommendations. So there might be things that are not part of our requirements, but they might be strategies or areas of improvement that the site survey team might make recommendations on, and they're for their consideration. And we'll list those in the letter as well. And then once they do any final submissions, after that, then they get an approval letter, and that's another form of documentation that is maintained online as well. So we have a shared file or shared folder through our Department of Health, and all of this documentation is maintained and backed up.
And that that database that you mentioned, do you know what it's called? Is it a platform?
Oh, it's through a, well, the applications themselves are submitted through OneDrive.
Okay. And so OneDrive takes the applications and collects the data for you and everything that you just said?
No, the OneDrive is only just the electronic submission of the application. They also submit one hard copy as well, and that's one that we've been maintaining a hard copy, and then although eventually, as we become more comfortable with having our electronic system, we'll probably be able to forego the paper copy. Although it's easy to access if with all the transition that goes on with new personnel, sometimes they're unable to retrieve their previous application, and so we're able to send that to them either electronically, or sometimes we're able to make a copy of it and send it to them as well. The latest version, I'm suddenly like blanking on the name of the program that we're using for the new application. It transitioned from Access to it's like right on the tip of my tongue, and I can't think of it.
Smartsheet. Yeah.
Smartsheet. Yeah, there she goes. Thanks, Kelly.
So I'm a huge fan of Smartsheet. Not a plug, I'm not promoting it, but I'm a huge fan. So
yeah, it was just probably about 1.5 years ago that we started the Smartsheet use. So we've needed to tweak it a little bit, but it's moved along really pretty nicely.
Very nice. We are almost at the top of the hour. I have several questions, and I was hoping to get some of the questions in the chat, but I think we got to most of them. I apologize if we didn't. So thank you all for joining today for the great discussion on the pre-hospital minimum criteria. So we are going to, and of course to our Evelyn and Morgan for speaking and answering our questions on that. So we're going to skip May. So have a wonderful month. Deep breaths. Do your assessment. It's going to be great. We're going to get so much valuable data from it, and have a great time at the conference. And then we will reconvene here in June. Let us know if you have any questions or need anything. Thank you.